cost savings in a free transgender clinic in Tijuana, Mexico, that combines hormone therapy and pre-exposure prophylaxis for HIV. So, HIV, yep.
Yeah, I think just back a little bit. Yeah.
Thank you. Thank you. So, well, we know that HIV in the U.S. It's definitely the Latino population is a key burden population, and in Mexico, even though the prevalence of HIV is relatively low compared to other countries, in Tijuana or northern border areas of Mexico have shown to have a higher prevalence of HIV. And for example, in subgroups of Tijuana, among men who have sex with men, there's about a 20% prevalence. In persons who inject drugs, it varies between 3 to over 12%, for example, for female sex workers who inject drugs. And among the deported migrants, about 1.2%. And transgender women, there's data in Mexico showing that the prevalence is between 14 to 41%. In a study, they've shown about 26% prevalence. Oops. So transgender women have been one of the groups most affected by the HIV epidemic globally. And in Latin America, there's data showing that 1 out of every 3 transgender women are living with HIV. And globally, there's data showing that the incidence of HIV among transgender women is about 50 times higher than other populations. So transgender women face significant violence and barriers to healthcare. In 2009, there was a study done in Mexico and showing that among healthcare providers, there's transphobia in Mexico and other middle-income countries. And there's studies showing that perceived stigma and discrimination in healthcare settings can be barriers for people to access healthcare services, either preventive or services. And in Tijuana, there's been several clinics that offer transgender health services, but some of them, have encountered severe financial issues, as far as sustainability. So HFIT, is a program that grew out from faculty and students from UCSD and UABC. It's a partnership between academic, community, and private partners. And basically, since 2016, there was it came to the attention of students and faculty as far as the susceptibility or vulnerability of transgender women and sex workers. So in 2016, a free transgender clinic was established in Calle Mutualismo en Primera. Is an area known for transgender women that are involved in sex works that congregate. So the clinic was structured as a primary care clinic, and it followed guidelines from a clinic led by Dr. David Smith in San Diego as far as providing primary transgender care. And among, with this program, there was a training course developed for UABC medical students and for certification for clinicians in Mexico to continue sustainability of the clinic. So the study objectives was to describe the cost for providing services, for providing hormone treatments to transgender women at high risk for HIV, and HIV pre-exposure prophylaxis. And to assess the cost, once we evaluated the cost, to assess the cost effectiveness of a primary transgender clinic that offers both pre-exposure prophylaxis and hormone therapy. Okay. Data for costs related to transgender clinical care were obtained from the clinic. So basically, the clinics have been providing hormone therapy since 2016. And the cost for PrEP was based on data from the government, since that's not being offered right now at the clinic. So the costs related to HIV care were obtained from published data from Mexico. So for the cost-effectiveness analysis, a Markov model, so that is a discrete mathematical model, was created to evaluate the cost and the effectiveness over time of providing PrEP and estrogen or hormone therapy to transgender women at high risk of HIV compared to standard of care. And the time for the analysis was set for 20 years. So the data was entered into the model, and the model followed on cycles of annual cycles for 20 years participants, hypothetically. So epidemiological variables were obtained for published reports and data from the HFIT clinic. Sensitivity analyses were performed to evaluate the model robustness. We also performed entered data in the model and compared it to actual data from other studies to see if it's if it was sensitive or if it was accurate. And the costs were estimated in 2017 US dollars, and the effectiveness was adjusted to quality adjusted life years. Both cost and qualities, or cost and effectiveness, were discounted at an annual rate of 3% per year. So this is the variables that were used in the model. Basically, the personnel costs were taken from actual costs for paying clinicians, nurse, and the time. The clinic generally focuses on transgender population about twice a week. Laboratory tests were based on tests for running creatinine levels for PrEP before we start PrEP, to run viral load testing, though I separated the viral load testing, to run tests for hormone like prolactin levels and blood chemistry to evaluate the use of hormones and PrEP. The cost was also estimated by the actual cost that the clinic pays for estradiol, and the cost for PrEP were based on negotiations with the pharmaceuticals and with the cost from a generic PrEP or emtricitabine and Truvada that came into Mexico called Mobitrem. Viral loads were based on equipment that the clinic has, which is a gene expert, through WHO arranged prices. The price for viral loads with this equipment run about actually lower, between $12 and $18, and the results are available in 2 hours. Costs associated with HIV infection were based on literature and reports from Censida and from publications. And demographic variables were based on the clinic population. So the clinic right now has 50 patients, transgender women, that regularly go to the clinic. Mortality was based on INEGI or life tables from Mexico. Mortality among people living with HIV were based on literature report. And the time we used to model the cost effectiveness was 20 years, but for sensitivity analysis, we varied between 10 and 40 years. HIV risk among transgender women was estimated to be about 4 per 100 person years. So it's not 0.04, it's actually 4 per 100 person years, and we varied the incidence between 2 and 6. PrEP effectiveness was estimated to be at 44% based on previous studies, and it varied between 20% effectiveness to 70% effectiveness. And the data, pretty much showed that with the data that the data showed that pretty much when we compared cost, of providing PrEP and hormonal therapy for transgender women, the cost per year of care is about $1,280, and the range is between $502 to $3,680. The range was based pretty much on what the cost of the medications. That there are some countries like Brazil where PrEP is much less expensive, in other countries, and other data. And HIV care costs, were based on literature reports, so $5,200 per year, and vary between $4,200 and $6,200. So the cost difference was pretty much cost savings. So this is just a cost comparison. How much does it cost to treat, to use PrEP and hormones versus HIV care? Now, when we run the cost effectiveness analysis, and we based, in a Markov model, that is a model that carries, hypothetically, the participants 1 year and in 1 year cycles. Basically, we found that the cost effectiveness of providing PrEP and hormones among transgender women was about $6,840 per quality adjusted life year saved, a gain. This is a sensitivity analysis. So, there's uncertainty about the HIV PrEP effectiveness. So, we found that, after 25% effectiveness, based on accepted thresholds for cost effectiveness analysis to consider a program to be cost effectiveness, the program becomes cost effectiveness, and that's based on the GDP in Mexico, which 3 times the GDP in Mexico, you consider a program to be borderline. More than 3 times the GDP is not cost effective. If the effectiveness is about 40%, that's our baseline. So if it increases to about 50% or higher, it can become cost saving, that the program actually saves money from HIV averted cost. PrEP cost, also the program, the model was very sensitive. So we lower the price to the cost in other countries like, Brazil, for example. The program can become very cost saving. So if the cost of the PrEP is $270 versus $600 or $800, it can become very cost effectiveness. And pretty much above $1,500, the program would not be cost effectiveness by our data. HIV risk, also, based on risk. So the higher the risk, the more cost effectiveness. Lower the risk, it becomes less cost effective until it becomes non-cost effective. Personnel cost, we vary the cost per patient, and pretty much we saw that it didn't really affect the cost effectiveness significantly. And this is a sensitivity analysis we use to evaluate the cost of PrEP, and at what point would PrEP become cost savings. And pretty much we found that a little bit below $600, so about $560 per month, per year, a PrEP program would become cost savings. So pretty much, we use this to leverage, or we're using this to leverage prices with pharmaceutical companies, or can be used, definitely. So the conclusions, from our studies, that HIV PrEP combined with hormone therapy for transgender women is likely to be highly cost-effective in Tijuana, Mexico, and similar settings, and can be cost savings when minimizing costs. Partnerships between government agencies, community clinics, and academic institutions to provide accessible transgender medical care combined with HIV PrEP or HIV care is critically needed and can be a very good strategy. So I want to thank David Smith for the training he provided in Mexico for the transgender clinic to start. Indersol, that right now is providing support to buy PrEP while we are trying to get enough funding to do a study, actual study using PrEP at the clinic. The clinic staff, patients, the transgender population from the area. Hospital General de Tijuana, that has provided significant support and training for clinicians and personnel. The Elton John AIDS Foundation, Desayunador Padre Chava, where the clinic provides care for migrants and for UCSD and UABC. Thank you.
Thank you. Are there any questions? I have a question about outreach to transgender women in Tijuana. How do you raise awareness about the clinic, and did you at all account for the costs of the outreach to bring transgender women into the clinic into your analysis?
Thank you. So we did, because we took personnel costs, so we do have an outreach worker who's actually from the transgender community that they organize meetings. She goes outside and provides information one-on-one. And pretty much, the biggest input of patients has been word of mouth. So many of the patients bring other patients, but we did take into account the outreach costs.
Hi. Sorry about that. Hi, Jose Luis. That was amazing, even though I don't understand a lot of the cost analysis, but it sounds wonderful to me. So I have a few questions. One, has this been shown to people that actually need to know to help negotiate costs and all of that?
Well, we presented a cost data to a symposium in Mexico a few months ago. It was actually in July. And, we talked to the pharmaceutical companies. The price for PrEP in Mexico is about over $2,000 per year. But they talked to us about a new generic that right now we were able to purchase. And, they lowered the price. So right now, for example, they provided the cost that I mentioned here in the study, and without any tax. So that's including Mexican tax, which is about 17%. So we have used it. We're trying to finish a paper from this data. We're trying to start a study, but we're struggling with enough resources. But definitely it's important to show this to government officials, Censira officials, and Mexico has a new government, has shown or has stated very positive, focus on the LGBTQI community. So I think it's a good moment to work on this. Thank you.
I have more if other people have questions. Okay, just two more, I swear. The effectiveness. I know, there are lots of studies that have showed the range should go up to about 75%, but we actually know that PrEP can be up to 99% effective. So when those numbers are taken into consideration, does it have to do with retention? Does it look at sort of what PrEP looks like over the year? Because obviously if people were taking it correctly, and that was, you could model it up to 99%.
Well, we modeled it based on considering that, we feel adherence would be helped with the hormones, because we have noticed that, transgender women, especially high-risk transgender women, are not likely to come for PrEP. I mean, we talked about PrEP and they don't care. We talked about hormones, which are expensive in Tijuana. Actually, that we need to negotiate with pharmaceuticals from hormones. And many women cannot afford, many transgender women that are low resource cannot afford it. So they definitely are faithful to the program with the hormones available. The other aspects, there's been discussions as far as with other studies that uncertainty as far as interactions between hormones and PrEP. We feel that one advantage that the clinic has is that we provide hormones, so we know what they're taking. We do a lot of work in discouraging their own use of other hormones, which happens. And so we feel we would probably have a good data, as far as showing we know exactly what they're taking. In other studies or other data that we've shared that we had shared from other investigators, they talked about differences in pharmacokinetic levels but they didn't know what hormones they were taking. And some are talking about almost the same levels as another participant not taking hormones, and some taking more than 40% differences. So right now we're submitting a proposal for ARB approval, and we're thinking once we get approved and we start people on PrEP, because we do have the PrEP, is to take blood samples, freeze them, and when we have money, we run PK levels to see what's going on.
Yeah, I mean, we could talk more about that separately. How many people do you have at the clinic currently?
Right now we have 50 patients that are transgender, and from them, that could receive PrEP, we have 20. So we have about 30 patients that are ready, and we actually contact another group from Ensenada. This is a very active group. It's a group called Ensenada. It's a very well organized. They actually have their own NGO, though they've been really struggling to get everything together. But we actually provided services to them last week, and we saw 10 new patients, and they, all of them were HIV negative right now. But we took surveys about their HIV risk and so forth, so we know they're significant.
Because the hormones, I agree.
Hormones seem to be something that might drive or bring transgender women into the clinic. Do you see that how long term do you think that would be? Like they're going to come back for their hormones. Do you think that they would be adherent to PrEP in that context as well?
Well, we've noticed that when we pay for PrEP, we provide the PrEP. I mean, not the PrEP, the hormones free of the PrEP. Is secondary sometimes in the discussion, but we're not providing it yet. But when we tell them we have the hormones, it's time for their appointment, it's time for them to get their new batch of medications. We usually provide 1 month at a time. I mean, they're very punctual. And the fact is that it's expensive, it's for Mexico. I mean, but because of the resources they have, it's expensive. Many of them were taking other hormones. They were mostly birth control pills, and they were having more significant side effects. So we have very good adherence as far as hormones. We don't know about PrEP yet, but yes. Well, thank you very much.